Hey there guys, Aaron Brocious again for our final presentation for the Johnston Community College Instructor Methodology class. So I suppose this will actually be the last time I talk to you guys, since this is the end of my final presentation here. So my presentation, as you just watched as I presented the PowerPoint, was about blood administration, and particularly pre-hospital blood administration. So we came outside. Obviously we can't teach this in class like we were supposed to, so bear with me as I kind of had to make do with what I have to present, kind of teach how you would actually, the application of administering blood, okay? So as we learned from the PowerPoint, from the presentation, so for us to administer blood, whether we're on a helicopter, whether we're on an ambulance, like some departments are doing in 911 systems, we're going to obviously either have a trauma patient, they've got penetrating or blunt trauma, or a medical patient, and at that point we're looking into their hemoglobin. So they've met one of those criteria, and now they have a heart rate greater than 120, a systolic blood pressure less than 90. Those are, especially with trauma patients, going to be the biggest things that we're looking for, okay? And then some signs of hemorrhage. So our patient has met that criteria. So now we need to make sure that we get the right equipment and that we do the right process, because this is a very, it's simple, but it can be dangerous if it's not, if the process isn't followed appropriately. So first thing we want to do is make sure that I have a second provider. So for almost any protocols in any department, I need to have a second provider. So a second medic, whether that's a supervisor, another medic unit, a second medic that can verify with me the blood, the patient, all of our rights for administration, okay? So for the sake of demonstration, my wonderful sister-in-law, Jade, who is behind the phone and the camera here, is my assistant, and she's also going to be my second provider. So I do have two providers on scene, okay? And also thank you for your assistance. So then I've got two providers. Now I need to make sure I have the right equipment. So what I do have, and I'll show you, is I've got my blood tubing. So this is our Y blood tubing, and I'll pull it out and kind of show you how that is set up. We've got our normal saline. This is our clear bag of normal saline. These are small demonstration models, if you will. So I obviously couldn't get all the full-size stuff. And then we have our blood, okay? And we'll talk a little bit about that, but we have our blood product there. What I don't have for demonstration purposes is an IV catheter in a person or a mannequin or anything like that. And I don't have a fluid warmer, which is what we would want as well, because this blood, as we talked about, is going to be stored in a cooler, something to keep it cold so it does store longer, okay? So you want that IV catheter, which was 20 or larger, so 20, 18, 16, or 14 gauge IV catheter. And that fluid warmer, there's a bunch of different brands, and we talked about a few of those. So I don't have those, but for the rest of the demonstration, we'll be able to at least talk through the basics of this. So the first thing that we want to do is I'm going to go ahead and hang my fluid. So I've got my makeshift IV pole here. So I'm going to go ahead and hang my saline. Now, as we talked briefly about in the presentation, the reason that we use normal saline and not lactated ringers. So a lot of our trucks, we carry both of those. So the primary reason is in fact that the lactated ringers actually contains calcium in the solution itself. And so that calcium can interact with the citrate in the blood that helps kind of store the blood. And that calcium, if it mixes with the blood in the tubing, can actually cause the blood to start clotting in the blood tubing. Now, if we're giving this to our patient and it starts clotting in the body, that's actually not a bad thing, because these patients are bleeding. So we do want to encourage clotting. But what we don't want is those clots to start occurring in the tubing, in the filters of the blood tubing, because then we're actually going to inhibit the administration of that blood to the patient, okay? So that is the main reason that we're using normal saline instead of lactated ringers, okay? So I hang my saline. I'm gonna go ahead and get out my blood tubing, okay? And I'll show you guys the blood tubing here. Let's go ahead. So the blood tubing, as we open it up, as you saw in some of the pictures from the PowerPoint, but we'll be able to see it a little bit better here. So we have a Y tubing. These do not have the normal drip chambers that you're used to in regular IV tubing that we carry on the trucks. So this drip chamber and filter is where all of that is going to happen. So I've got my Y tubing, I've got clamps. I'm going to go ahead and turn these clamps off. I want all of my clamps off before I start any administration of the product, okay? My clamps are good, my tubing is good, my chamber, I don't have any holes, my filter is intact. Now this is that 170 to 200 plus micron filter that we need to use for blood administration to get out any of those small particulates, okay? And then we have the rest of our tubing and our final clamp before we get to the patient side of the tubing down here, okay? So we do have on this tubing, we only have needle ports, so we don't have these twist-on ports like a lot of our IV tubing. But so at this point, our tubing's intact. We've been able to see, okay, we've got good filter, good tubing, our roller clamps, everything is shut off, okay? So the first thing that we're gonna do is we are going to prime the line, just like you're used to doing with just a regular IV tubing, normal saline, LR, whatever you're using. We're gonna prime the line with the saline, okay? Reason we're gonna do this first is so that we don't waste blood, okay? And you'll kind of see how that also comes into effect at the end of the administration as well. So, because I don't want to flush this line with blood and just let, blood that is very important, very precious, just go out onto the floor of the ambulance or the ground, okay? I'm going to prime it with saline and then put the blood in after, okay? So we'll go ahead and spike the saline. Take it off here for a second. So just going to spike my bag. Hang it up, and at this point I can open up this roller clamp for the saline, and I want to let it start filling my chamber here. So you can see it start to fill my chamber. So now this is an important aspect of it, and I'll tell you why in just a second. Okay, so I've got the chamber, the bottom half of the blood tubing chamber is full, okay? And so this is important because now, once I attach my blood to the second arm of the Y, that blood, it needs to fall onto fluid, okay? I don't want that blood to fall onto the filter, because if it falls and hits the filter directly, it can actually hemolyze the blood, and it can actually hurt some of those red blood cells. It can actually damage the product before it even gets into the patient, which at that point is going to either be detrimental or just not beneficial to the patient, okay? So we just want to make sure our chamber is full of saline all the way up past the filter, okay? So at this point, this one actually has like a safety ball, if you will. So it'll actually stop anything from hitting that filter directly. But once I got that floating and I know I'm up high enough, we know that we're full enough on saline, okay? So at that point, I can go ahead and just flush the rest of my tubing. Again, just like you do with any other blood or fluid administration. We're just going to flush our line, and there we go. All right, so I've got saline out the end. My line is primed. There's no more air in the line, no bubbles. Again, I'm going to go ahead and turn my clamps off. Okay, clamp is off to the saline. Clamp is off. Again, this isn't on the patient yet, but clamp is off to the distal end of our IV tubing. Okay. So next thing I'm going to do, and again, I would do this with my partner, is I'm going to confirm my blood, okay? So in this case, for demonstration purposes, I actually have an O positive red blood cells, okay? So this is packed red blood cells, so this isn't whole blood, this isn't platelets, this isn't plasma. This is going to be 1 unit of O positive packed red blood cells, okay? So I'm going to confirm, depending on, if this is a transport situation, I'm going to confirm that, I actually have a patient that can accept O positive. We know from the class that O negative is the universal donor. Reason being that there is no RH factor in the O negative blood. So most of your programs that carry just generic trauma blood products are carrying O negative, because I can give that to really just anybody, and I'm not going to be too concerned about some type of transfusion reaction, okay? So, but for the sake of this demonstration, this is O positive packed red blood cells, okay? So I'm confirming that it's in date. I'm checking my date. I'm checking, the right patient. Obviously, if they're in the back of my truck, they're probably the right patient. I'm checking that this is the right medication or blood that I want to administer. I didn't grab the wrong bag or the wrong, blood type. So I've got O positive, packed red blood cells. It's in date. I'm confirming my patient. I'm confirming again that they meet the criteria, blood pressure, heart rate, whether they're trauma or medical. And then if I have access, I am confirming with labs. I'm looking at hemoglobin. I'm looking at hematocrit, okay? So confirmed with the patient or by my second provider. So then I'm gonna go ahead and I can hang my blood. So once the blood is hung, this is where it can get a little tricky just because we have a lot more moving parts here, okay? Most of us are not used to having to spike 2 bags on the same line, all right? So again, I'm gonna go ahead and remove my cap. I'm gonna spike my bag. All right, so obviously just like we see, this chamber, this line does still have air in it, so I need to flush that, but that is why we have the saline already filling this up, okay? So again, I'm gonna confirm, and this is where I can go ahead and attach my line to the patient, okay? So I'm not gonna be taking any air. I've got both products spiked on both ends of the bag. So I can go ahead and attach this to my patient through that 20 or larger gauge IV. So we're gonna go ahead and attach this to the ground for this demonstration, but that's to the patient. So then, and this is important, I wanna keep the line for the saline turned off, okay? So reason being is if I start administering this blood, it can actually, in this small chamber up top, it can actually start mixing. And if I have both open, that blood can actually come back up this chamber. And if you've ever administered blood, you've probably made this mistake at least once, and you'll start getting blood in your saline bag, okay? And it just now looks like a mess, and it's not fun, okay? So to make sure that the clamp to the saline is off, and then I can open the clamp to the blood, okay? So I can start filling my blood. You can see it running down the line here, and it starts moving into my chamber, okay? So my blood line is primed. Then all I really have to do is open it up to the patient, okay? So coming down to my final clamp, and I'm gonna go ahead and start administering the blood. So you can see it start going in the filter. It's hitting saline. It's not hitting the actual filter, or the actual filter. So the initial administration is gonna be just the saline that was primed into the line. But then eventually we do see the blood starts to mix. We get the blood coming out, and now we see that we're administering blood, and we've got blood products. I can now titrate this back, okay? So with this administration, I've got the blood products going into the patient, okay? I'm just gonna go ahead and shut this off so we don't drain everything on the ground here. So a couple things that we want to keep in mind and be careful with. So even though I have checked my patient, I've checked my route, I've checked my line, I've checked all of those rights of administration, some patients can still have that transfusion reaction and adverse reaction. So something that we did before that we already talked about in the presentation is we have that good baseline set of vital signs. Now that, you may have from first responders, you may take it yourself, but that first initial baseline set of vital signs is what I'm gonna use after administration to see, am I getting improvements in blood pressure? Am I getting improvements in heart rate, okay? The important vital sign that we don't always check on all of our patients that is good and necessary in this one is temperature, okay? So these patients, one of the first signs that we're gonna see of a transfusion reaction is gonna be an increase in temperature. It's the body starting to heat up, it's starting to say, something is not right. There's blood that is in my veins that is not cool. I don't like it, and so the body starts to heat up. You may start seeing a redness or a swelling in the area of the infusion at the IV site. If that happens, first thing we're gonna do, shut the blood off, okay? First thing we're doing is coming up here, and I am shutting off the blood. I don't want any more of that blood getting in there. If I need to take the actual IV out, I need to go ahead and do that, because I don't want it, if they're having a negative reaction to this blood, I wanna go ahead and shut that off so they don't get any more, okay? So if everything's going well, we don't have redness, temperature checks are going well, I'm checking vital signs at least every 5 minutes, okay, for the first 15 minutes, depending on the after 15 minutes, depending on the patient's severity, how critical they are, we may continue every 5. We may actually just go to every 10, 15, depending on, again, that patient status. So if everything's going well, we're checking fluid or vital signs every 5 minutes for the first 15 minutes. If everything's good after 15 minutes, then I can continue that administration. Now, with some of our trauma patients, for example, you may think, and this is very true, that I need to get this blood in quick. They're bleeding out, their blood pressure's low, their heart rate's through the roof. I need to get this blood fast. I can't just sit here and wait for it to drip in through a 10-drop chamber here, right? So with that, once we have been through about that first 10 minutes or so, and we've given at least 50 mLs of blood, if there's no negative reaction, I can potentially squeeze that fluid in. So I can actually put a pressure bag on the blood. I mean, I've even seen, flight medics, flight nurses, guys actually just start squeezing the blood to get it in quickly, okay? Now, the big caveat with that is we want to make sure there is no negative reaction before we just start squeezing blood into the patient, okay? Once we've determined they're kind of past that window, we don't have that negative response, we can administer it a little faster if we need to, because this is a life-saving intervention at that point, okay? So, let's say, we've checked, patient's receiving the blood, everything's going well, this blood has been flushed in and we're almost empty, okay? The blood is running out in our fluid bag here. Another reason that we have the saline is, again, we have all this blood that's left over in the line, okay? And we don't want to just waste that and disconnect it and toss it in the trash, because, there's a good, 20 to 30 cc's of good packed red blood cells that are in this line, that we could still give to the patient. So once my blood is out and that's turned off, then I can open my saline back up and allow that saline, open it back up on both clamps, and then we can allow that saline, it's going to flush the remainder of the blood in that line, it's going to go ahead and flush it out, okay? So it's flushing out the blood that's in the chamber, in the filter. My bag is not quite big enough. You would have normally a liter bag of saline here. But it's going to continue to flush, and it's going to flush the line, and it's going to get all the rest of those blood cells and that blood that's in the line get to the patient, okay? So we're not wasting any blood, all right? And so really that's 2 of the biggest reasons for the saline is at the beginning to flush that line, and at the end to flush that line, again, to save the blood, okay? So once we've continued and we've got everything administered, then we can go ahead and obviously just disconnect it, just like we would do with anything. And if necessary, depending on our protocol, depending on the patient, what they need, I can spike another bag in this with the same bag of saline. I can spike another bag of packed red blood cells going through that same check process. If they need plasma, if I have whole blood, I can go ahead and administer that as well, okay? And then once we're done, we're just going to continue to monitor our patient and hopefully get them, if they're needing blood from us right now, they're probably needing an OR somewhere so they can stop this bleeding, okay? And then once we get them there, just give your report, and then just documentation. Documentation is very important, like we know with any patient, but with blood administration, it's tracked by Red Cross, blood banks, everything. So we want to make sure that we document, what kind of blood was given, how much of the blood was given, was any of the blood wasted, things like that. So it's just another aspect of our documentation, which should already be pretty thorough, okay? So hopefully you guys learned something from that, enjoyed the presentation, enjoyed the demonstration, and I look forward to seeing you guys out in the field at some point. And thank you guys, I appreciate it very much.